Okay, so this slide would actually start with what is HIV and AIDS. So we all know that it's a HIV stands for the human immunodeficiency virus, but it can lead to the acquired immunodeficiency syndrome, that is the AIDS, if it is not treated. So we know in children, no, because they are being infected by your either the mother from the mother, no, that they can be HIV-1 and HIV-2. Both are from the retroviral viruses. Although the HIV-2 is milder disease, the course is with longer time to develop to AIDS. The problem is that it is more resistant to your NNRTIs. Unlike some other viruses, we all know that HIV cannot be cured. So if you have to start the treatment, you have to be treated for life. Okay, so the staging no, is really not different from the adults, but um, the response of children may be accelerated compared to the adults. So they would usually start with an acute HIV infection, which is within 2 to 4 weeks after the infection with the HIV or the virus, and it may also present like flu-like illness. In children, it's more of lymphadenopathy and some skin rashes that may last for a few weeks. And so it is like just some other viruses, no? But we all know that this is the body's natural response to infection. And due to the large amount of virus in their blood, they are considered very contagious already at this stage. And now, a fourth generation antibody antigen test or a nucleic acid test is necessary to identify patients at this stage. So the stage 2 is the clinical latency, where you have the HIV inactivity or dormancy. So they are asymptomatic at this point, but the HIV or the virus is still active and reproduces, but at very low levels. So sometimes they may not be sick no, or during this time, or they may not have that symptoms. And that's why they don't uh, have themselves tested, or they may not be taking their drugs. But in children, this stage may be shorter than we expect from the adults. For example, if the child has been infected or has been exposed to from the mother um, during pregnancy, this may be as long as 10 years, but as can be as short as several months. So at the end of this stage, the viral load will now go up and the CD4 cell count goes down. So the, the child may have now the symptoms. And so it's that stage, no, the stage 3, where they are already considered as AIDS. This is where we get most of our patients, no, that they already present with AIDS-defining illnesses because they were not tested during infancy, or were not given the drugs, no, or because they were exposed to their parents or to the mother. Okay, so we all know that in children, the HIV transmission can be uh, through perinatal transmission during the pregnancy, labor, and delivery, or even during breastfeeding. Um, the unprotected sexual contact is for the older age group. So we have seen earlier that teen pregnancies now are increasing now. So they can even start their sexual menarche no, at the age of 9 or even 8. Okay, so at 8 years of, and then through occupational exposure. So when they are in their actually older age group. Okay, so HIV is not transmitted by casual contact. So we all know that most parents are actually concerned about those exposing their children to HIV positive children. So it's not transmitted through working or playing, close mouth kissing. Okay, we can also practice that now for the COVID-19 2019. Shaking hands or public pools, hugging, and even the public toilet. So HIV is not transmitted by air, food, or even the mosquitoes, and does not survive outside the body. So you can be at risk if you have the following. You have sex without a condom, blood transfusion, exposed to contaminated injected equipment, and for infants through the mother. And another actually is sexual abuse for children. So we get more of, we are now making them more aware that HIV can be transmitted through sexual abuse. Okay, so how do we diagnose HIV in infants? Now, these are for infants that were exposed through their mothers. So it is recommended that we do HIV virological testing, meaning we do the HIV DNA test, the DNA PCR, okay, or the RNA PCR. This is because and it is recommended for infants and children below 18 months of age. This is because there are transfer of maternal antibodies. So if you do the antibody test to infants and children below 18 months of age, it may give you a false positive result due to the presence of the antibodies from the mother. So another is that it is strongly recommended that all HIV exposed infants have that virological testing at 4 to 6 weeks of age, or at the earliest opportunity thereafter. Oh, in our case, in our PMTCT program, it is being done at 4 to 6 weeks of age. So this is the guideline for uh, the diagnosis in infants. Okay, so virologic assay would directly detect your HIV, RNA, or DNA through the polymerase chain reaction. So it's a PCR test. So a positive virologic test should still be confirmed by a repeat virologic test on a second specimen, which is usually done 6 months after the first test. Now, if for infants, no, age more than 18 months, no, so a positive HIV antibody test, so it can now be done. So it's easier, but it's still with a confirmatory test. You either using the Western blot or your IFA or your immunofluorescent antibody assay. Now, exclusion of HIV infection in infants, no, it means that that's the only time we will say that the infant is HIV negative is done in a non-breastfed infant based on 2 or more negative virologic tests, with one obtained at the age of more than 1 month, so that is the 4 to 6 weeks, and one at age more than or equal to 4 months, or on 2 negative HIV antibody tests from separate specimens obtained when the child is more than or equal to 6 months. Okay. Uh, this algorithm is actually attached in the PMTCT policy, no, of the DOH, the 2017. No, we already have it being signed. No, and I hope, and then you will see this actually in the AO. So this is establishing the presence of HIV infection in HIV exposed infants less than 18 months. So this is the algorithm that you will use. Okay, so that's what I already discussed. Now, this is another algorithm that is testing for, that is on the AO for the HIV testing that is dated 2017 also, which is, you can see that the testing strategy for HIV diagnosis in low prevalence setting, because the Philippines is still considered as a low prevalence setting. So the basic, the important thing here is that you have to perform several tests before you can say that the patient is, that the child is negative or the child is positive. So actually it has to be on this side that two negatives, no, consecutive negatives is report as HIV negative. But if you have also three positives, no, either this is actually consecutive, so different sites dapat ho ito. So it has, you have to report it as HIV positive. But if you have tested 2 out of 3, no, it can still be HIV inconclusive, but you have to retest in 14 days so that you can have, if it is really negative, so no 2 tests negative, then you can then actually say that it's negative. But if it turns out positive, then the patient is reported to be HIV positive. Okay, in children, the staging for HIV disease is actually not somewhat different from the adults, from the clinical stage 1 and 2. But on the clinical stage 3, okay, so in clinical staging 1, we usually see patients now having hepatosplenomegaly or enlargements of the nodes. But on clinical stage 3, we always see patients with oral candidiasis and mostly like TB and the recurrent, no, severe bacterial pneumonias. So majority of our patients here in PGH, when they present, they would usually have the moderate malnutrition that we see in HIV. And so these are the oral manifestations. And for clinical stage 4, usually they would have the PCP, pneumonia, and this one, the severe stunting or severe malnutrition, and also several um, types of bacterial infections, but mostly TB and pneumonia and also some, we see some of them with crypto and also the other um, uh, opportunistic infections. So in children, no, we just do the clinical categories, no, like with immunologic categories with so N, A, B, C. So, and so the immunologic is the suppressions or the CD4 count. So if they have the severe signs, then and then there's no evidence of suppression, no, but it's still C1. So, but basically, um, the update is that once they are diagnosed, they have to be given the drugs right away. Okay. So, and the priority is actually for children in the first year of life. Now, I will have to skip this because I have, this is actually for the testing, the slides for the testing. So when to start ARTs in infants and children younger than 10 years of age, right away. So again, we have to start it once we have the positive test, okay? And positive test, and then even if we're gonna wait for the confirmatory result, we still have to start it. I don't base it on the CD4 count anymore. Okay. So these are the drugs that we use. Several drugs have been, it's actually different from the adults, mainly because of the preparation. So we need for, especially for infants, we need it in the syrup form. But the problem is that we don't, if we don't have the syrup form, so what we do with the tablet is we do the paper tabs. No, so it's really very difficult because when we do paper tabs, it has to be done by the pharmacists. So, and it has to take some time, no, to, because they have to weigh it, no, based on the weight of the, also of the patient. So it's very important that for, especially for pregnant women who are gonna deliver the baby, no, and the mother is HIV positive, we recommend that they also have um, a, um, consult, no, pediatric consult, so that a few weeks before their delivery, expected delivery, so that we can explain what to give to the child, and then what to, on the, also on the feeding, infant feeding, and also the testing. Sorry for that. Okay, so these are actually the drugs, drug interactions and other suggested. Okay, now this is for the TB in children. So I would just like to say that we adjust the dosing of the and the timing, no, of the ARV drugs when a patient, when a child with TB has a taken or started TB drugs. Okay, the basis is to delay the ART initiation in patients with who had just started TB treatment, no, with at least within 2 weeks, because of the higher incidence of your iris. No, when they are initiated, when the ART is initiated within 8 weeks, but it now has been lowered to at least 2 weeks. So you start the TB treatment, and then after 2 weeks, then you can start the ART treatment. So these are actually what we look for, children living with HIV, with also with TB. So I just want to also include, no, that there are other drugs that are being given for prophylaxis, which is very important for infants and children, because we have to cover for the PCP, no, pneumonia. So all children actually, we also start HIV exposed and infected infants. We still initiate starting it uh, for the prophylaxis at 4 to 6 weeks after birth, and also and it has to be until, no, the HIV infection is excluded. But for children with HIV less than 5 years of age, then we initiate cotrimoxazole prophylaxis. Okay. The others, these are the other slides that show you the other opportunistic pneumonias that can be seen. Okay. And the steps. I'll be leaving these slides to you so you can actually use in the clinics. So you know that pneumocystis infection is very common in HIV, in children also with HIV, and also those who are immunocompromised, severely immunocompromised. So that it is, the diagnosis is through symptoms and fever and dyspnea, and then the O2 levels, and also the chest radiograph. Okay. So recommendations for routine monitoring is to do viral load monitoring at 6 months, and then at 12 months, and then every 12 months thereafter, if the patient is stable on ART, no, to synchronize with the routine monitoring of the patient also. Okay. I think I have to skip the the other key facts on HIV. What I don't have here is on the breastfeeding. Okay, so um, I will be addressing the breastfeeding on the Breastfeeding Congress this August. But again, you have seen the slide of Dr. Ramadamba that we have the HIV Summit, that together with OB and also the adults and the PIDS or the pediatrics, that we do not recommend breastfeeding for HIV positive mothers. We have to let them know that there's still transmission, even if the mother has less than 1,000 um, copies. No, we still do not know that that if they can still transmit the virus and to their child. And also several materials have been released already on breastfeeding. That the latest was in for European countries, that they still have about 2% no, of transmission if through breastfeeding, even if the mother are taking their ARV drugs. So the stand for us is still not to breastfeed if the mother, even if the um, viral load is very low, and adopt no, the measures on AFAS.